Okay, so thanks, Glenn, for that kind introduction. So again, myself, I'm Val Maharaj, former fellow and now faculty here at the university, and I'll be talking about living with an LVAD as a destination. And then soon after, Michael will talk about symptom control and palliative care revolving around LVADs. So no disclosures to mention for this presentation. So the objectives, we're going to talk about definitions of heart failure, indications for an LVAD, and then the benefits and risks associated with having an LVAD. And then afterwards, what it's like to live with an LVAD, just to give you a little bit of insight. So of course, as we all know, heart failure, it's really just a syndrome where your heart is not able to keep up and pump as much blood as the rest of your body would like. And you might feel like you're more short of breath, you might feel fatigued, you might have low blood pressures. So this is a clear clinical syndrome that we see repeatedly. And then a cardiomyopathy is actually the reason that people get heart failure. So when we use these terms in the hospital, we might say ischemic cardiomyopathy, for example, like was your heart failure from low blood flow or from prior heart attacks, or was it from prior arrhythmias? So just a few definitions that I think people may confuse every now and then. Advanced heart failure, and hopefully this picture shows up. It's not showing up too well for me. There we go. So all these societies, American Heart Association, American College of Cardiology, Heart Failure Society, European Society of Cardiology, they all had their own individual definitions of what advanced heart failure really means to them and their patients. But the overarching theme between all of these organizations that advanced heart failure patients have severe symptoms, recurrent hospitalizations, and severe functional impairment despite being on optimal medical therapy. And when you look at these people, you could say they're refractory heart failure, or they even have end-stage heart failure. And every time we do serial testing, the testing reveals the severe heart dysfunction. So more than 6 million Americans live with heart failure, and they believe this will grow to 8 million in about the next actually 8 or 9 years. And about only 5% of these people will actually progress to advanced stage D disease. And as you can see here, it's actually higher in African Americans versus Caucasians, but it's similar between the two genders. And this is a classic graph that they show us all throughout training and fellowship and med school, that here you have your quality of life chart and how much care you're receiving. And people are first diagnosed with heart failure right here, and they get a lot of support. And then they get a lot of improvement, but over time, you can slowly get the dwindles. And every now and then you get hospitalized, and then you get some diuretics, you get a little better, and then still having some dwindles, and then another severe hospitalization, and maybe you need a stent, for example, or you need like a pacemaker or defibrillator. But these people who are on this advanced course end up requiring more care and have more decrease in their quality of life. And this is where advanced therapies can actually come in and help. So aging is big in heart failure, and of course across all of cardiology, that aging of itself leads to progressive decline in function of the heart, and this is due to a lot of biochemical processes. On top of this, people just generate and acquire a lot of different risk factors and comorbidities that promote the development of heart failure and actually worsen heart failure. And there are certain lifestyle things that we can do to actually reduce this, actually even starting from an early age. So what advanced therapies are available? And of course, we have continuous IV medications like dobutamine and milrinone that many of you may have been on in the past. But we know this is really just a stopgap, a Band-Aid, so to speak, that this is either for improvement or to get you to surgery or to get you to transplant, but it's not something that we like to do long term. And then while people are in the hospital, we have all these temporary devices that can be used to, again, help people get to their LVAD or get to the transplant. But again, they're really only used as inpatient use. We do not have people that go home on this. And then what I'll talk about the rest of the talk will be durable or permanent ambulatory mechanical support that we call LVADs. I show this slide to say that, every year the amount of donors and the amount of recipients and transplants that actually occur has been increasing steadily every single year. And actually last year, despite COVID, 2020 was our best year regarding life-saving transplants. But for each person that gets a transplant, they estimate between 18 and 19 people are still waiting on a list, awaiting their transplant. And for other organs, lungs, for example, or liver, for example, you may not have a lot of alternative therapies to get these people through the transplant. And at least fortunately, with hearts, we have these LVAD devices. So as an LVAD, as people know, it's a mechanical pump. It's a rotary pump, and it's connected to the heart via various cannulas, and it does require an open heart surgery. And originally, when they first came to the market, they're originally just used as a bridge to transplant, meaning similar like a stopgap, as a means to get people to improve their quality of life and improve their function and to get them on the way to transplant. But now, more recently, in the last 5 to 10 years, we've also been using it as what we call destination therapy. And by destination therapy, this means that this is an LVAD that we think will be with you for the rest of your life. And we're not looking for any other alternative therapy for your heart failure treatment. And nationally, the average survival is between about 4 and 5 years. As you can see, the different generations, starting with some of the more pulsatile devices and then getting to the continuous flow devices, they've gotten much smaller, less moving parts, easier to use over the subsequent generations. And this is another slide also just showing that the HeartMate Thoratec, HeartMate 2, HeartMate 3, hardware when it was on the market, each subsequent generation of device has been getting smaller and smaller. And this is another schematic showing how the inflow cannula is connected to the apex of the heart, the left ventricle primarily, and then blood will actually come down through this inflow cannula, and a motor or a rotor will actually get spun magnetically through this motor and actually push, so to speak, the blood out of this outflow graph towards the aorta. And as you can see, it comes out over here. This motor is then connected via a drive line that comes out through the front of the abdomen, and this is actually connected to the controller and the battery packs. Here at the university, we look at, when people are getting ready to proceed with advanced therapies, we do, as people know, a rather large evaluation regarding, are they good candidates for LVAD therapy? And we do this evaluation primarily to make sure that we don't cause any undue harm along the way. So it's a major surgery, it's a major commitment, it's a change in lifestyle. We want to make sure that the people that are chosen for this therapy are going to do the best with it, and we're not actually going to cause any harm along the way. So the main contraindications that we see are just irreversible disease of other organ systems. So if you have irreversible liver disease, kidney disease, neuromuscular disease, prior major strokes, things like that, those are really the absolute contraindications that we look at prior to proceeding with LVAD therapy. So the benefits, why do we do such a therapy like this? And this is from actually the Abbott patient brochure, but from the Momentum 3 trial, survival at 2 years was essentially paralleling heart transplant. That we had a 2-year survival of about 81%, and 79% of people improved in terms of their quality of life and exercise tolerance. That more than a majority of people actually had a 2 times increase in their 6-minute walk distance at the 2-year mark. So to actually have reduced symptoms, improve survival, and to have more actual endurance are all good things. And these are the reasons that we look at LVAD therapy. This is a common slide that's been published around a few times now, that essentially it goes through the different trials of LVAD therapy over the last almost 20 years now, where OMM is optimal medical management, and this is just a group of patients in the original rematch trial that were just using medical therapy. And with LVAD therapy and the subsequent generations of each LVAD, how survival has actually improved substantially, where now, as I was saying before, that survival at the 2-year mark is really approaching transplant, our gold standard. This is another slide just to show that quality of life at 6-minute walk time from pre-implant to 1 year across all age groups actually improves substantially. Sometimes people may think, all right, this type of therapy isn't necessary for me. I'm, 74 years old. Maybe I've lived a good life, and that's certainly within your prerogative and your decision. But we have had a lot of evidence that people of multiple age categories actually show a lot of improvement here at the university and other centers around the nation. Life with an LVAD, as I mentioned before, about 9 out of 10 patients are still alive with their LVAD after 1 year. People will actually feel less short of breath, less swelling. You might have more energy, although you do have to pay that upfront cost of going through a major surgery. So for those first few weeks to even months, you may feel a little worn down. You may have to go do cardiac rehab or have a short inpatient rehab stay at a physical therapy unit. But over time, people do actually feel a lot better. Contrasting that with life without an LVAD, a lot of people fall into one of these two categories, that the sickest or even the less sick patients may not be alive after 1 year. And we know this is common with medical therapy and even using inotropes like dobutamine or milrinone, that these therapies just are not as beneficial for patients in terms of improving their quality of life and quantity of life. So again, LVADs are not without risks. There are certainly risks that come with this procedure. A lot of it is within the first year, so what complications might occur. And a lot of people do get readmitted, whether it's for things related to the LVAD, whether it's actually just heart failure. About 10% of people may have a stroke. 2 in 10 people, 20% of people might have an infection related to the LVAD, and another 20% of people might have a serious bleed related to the LVAD. And again, we haven't completely treated the heart failure. You still could have heart failure, and you may still need to watch your weights, watch your salt intake. So a lot of this doesn't necessarily go away. This table here on the right, I broke down common emergencies depending on whether it's specific to the LVAD, related to the LVAD, or unrelated to the LVAD. And these are all things that happen with people that come into the hospital. This is a paper that was published about 6 or 7 years ago that showed people who have an LVAD and how they die. And Michael may get into this a little bit later as well, but certainly there's this early death that can happen post-operatively, and this is something we all try and avoid, and we do our best within the intensive care unit to prevent this trajectory. People can still have persistent heart failure, and other organs may start to fail as well. But most people actually do see this big improvement, and then they have improvement for a long time, and then something acute or chronic may happen as well. So when we talk about LVAD therapy, and certainly Michael's going to get into this as well, we want to do what's most important to the patient. And there are many things that go into that decision, and we just want to do what's best for that person. And if ultimately that person decides, this therapy is not for them, we are still going to support them, be their providers, be their doctors, with any decision that they choose. So just a few other questions about actually living with an LVAD, some frequently asked questions. Certainly the daily checklist of things you have to do on a regular basis. So you have to make sure that equipment is working properly. And we, of course, test people and make sure they know how to work all the controller, make sure they know how to charge the device, make sure they know how to plug it in, make sure they have sufficient power at all times. And we make sure all those things are in place prior to them even leaving the hospital. The driveline, of course, has to stay clean and dry, and people would change that either on a daily or a weekly basis, because certainly this can become infected and then cause issues down the line. You are allowed to shower. Often we will give actually certain dressings for the shower, but you actually cannot submerge the device. So no hot tubs, no swimming, no lakes, things like that. And then of course, you're still at risk for having heart failure and having heart failure exacerbation. So we still look at watching your diet, making sure you exercise, getting good sleep. A lot of people may not be able to sleep entirely on their stomach as if they had before because of where the drive line is. So they may have to change their position to something that's a little bit more comfortable for them. And then, of course, there's still going to be with certain medications. We still look at trying to control blood pressure, trying to control the fluid status, and then people are on blood thinners as well for this LVAD therapy. Other considerations, as I mentioned before, the post-operative recovery it's quite a recovery. Most people spend about 2 weeks or so in the hospital, and it's not uncommon that to require a short inpatient stay at a rehab unit or at least outpatient cardiac rehab afterwards. But often I'll tell my patients, it might take a good 6 months even to feel like you're getting back to your normal and allow that breastbone, the sternum, to really heal. You are allowed to travel. You're allowed to drive. You're allowed to take airplanes. Often you have to let TSA know that you have this device and you're not supposed to go through that screener device. And then actually it's important to know wherever you are where the nearest LVAD center is, especially if you're out of state or if you're on the West Coast. If something were to come up, you'd know, what would be a good hospital for me to go to for care of my device. And then lastly, the other thing I'll touch upon is people can be intimate. People are, certainly can have sexual relations. We do advise we try not to have any pregnancies though, and when people are on the device, because that can cause other complications as well. So some take-home points that, as I mentioned earlier, that heart failure is extremely common, but only a minority of people will actually transition to advanced disease. And of those people who have advanced disease, the LVAD is a well-established treatment with longevity, quality, and quantity of life approaching transplant, our gold standard, at least at that 2-year mark. So there are certainly risks and benefits associated with LVAD therapy, and it does require a change in lifestyle, but we do think it's worthwhile for a lot of our patients that we see. These are some resources that I think certainly, Glenn or Scott or other people who have devices, I'm sure have come across before. I really like my LVAD, and they actually do have a Android or iPhone app, and that's actually helpful because, as I mentioned before, if you're traveling, it can actually locate based off your cell phone where the nearest LVAD center is. This patientdecisionaid.org, that's actually from the University of Colorado, and that goes through a lot of pros and cons and benefits and risks as well of getting an LVAD therapy. And it's good to show other family members if they want to learn more about what their family member is getting into. And then the website from Abbott itself also has a lot of information for patients regarding HeartMate LVAD therapy. So with that, I'd like to thank the heart failure team at the university. Of course, all the attendings that I've worked with, I feel like I've gotten great training from all of them. And then, of course, all the support staff as well. I've really enjoyed my time at the university, and I'm going to be here for the long haul. So for any people on the call, you might see me rounding in the hospital on occasion, and I'm glad to be here.
So thank you for the invitation, and thank you, Val, for the introduction to this topic. I've worked as a nurse practitioner at the university hospitals here now for 16 years, 11 of those as a hospital medicine provider, and the last 7 years in palliative care. And certainly working side by side with folks like Val has been a rewarding experience. And watching the evolution of these devices come and go, and the transitions from them only being available for pre-transplant use to destination therapy has happened within my tenure here. I think I want to say the FDA approved LVADs as destination therapy as recently as 2002. So it's a fairly young kind of discipline when it comes to looking at this as destination therapy. And we can focus on symptom management for sure, but I also want to talk about discontinuation of the device at the time perhaps it seems like it's necessary to do, and how we go through that decision process and supporting you through that. So that's hence the title of the talk here. I'm going to just spend a couple of minutes talking about palliative care, because I think it's a moving target for some people in terms of what it is and what it isn't, and we have an identity problem in palliative care. So I'll try to explain what that is. Palliative care is a discipline that provides support and care for patients of any age across the lifespan. So I have palliative care colleagues who work in pediatrics as well as in adult medicine, and it's a board certified specialty. So physicians go through fellowship training and staff status similar to other board certified disciplines. Definitions of palliative care vary. I like the World Health Organization's definition, so I won't read it in great detail, but the part I really like is we have kind of a bifold principle indication. One is when patients have life-threatening illnesses, although certainly we have patients who have chronic illnesses that perhaps do not have limited life expectancy associated with it. And hopefully we do our work by early identification and impeccable assessment and treatment of pain and other problems, and focusing not only on the physical manifestations of pain, but also the psychological and spiritual aspects of who we are as human beings. The colleagues on the team I work with here at the university include physicians as well as nurse practitioners and PAs, but I also have two full-time counselors that work with me inpatient, and a chaplain that works with me full-time to try to incorporate those various aspects of our humanity into the conversations we have, especially when we're talking about something as specific as LVAD implantation and the lifestyle changes and the quality of life concerns that kind of arise from that. So another definition by CMS or the Medicare folks is palliative care is patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. The word palliative comes from the Latin word pallor, which means to cover. And you can kind of extrapolate that to when you see the term pallbearer at funerals, or the pall is actually the covering cloth on a casket that you see in funeral homes and in churches for religious ceremonies. So what is palliative care and where did it come from? The movement began in the 1980s, again, kind of within most of our lifetimes probably, gaining momentum in the 1990s. And the initial goal of palliative care as a discipline was to move the concepts of hospice care upstream. In other words, hospice being a discipline that usually involved taking care of patients as they approach the end of their life. But many of the principles and tenets of hospice care really are applicable to patients who weren't at approaching the end of their life. Good symptom management, quality of life considerations, goals of care, using those concepts as part of an interdisciplinary approach to patients as they navigate kind of the rapids of serious chronic illnesses. So the idea was to move those upstream. Hospice was formally established, if you remember, back in 1974, again, not that long ago, and became a covered Medicare benefit as recently as 1983, and did not extend to residents in nursing homes until the late 1980s. So fairly young discipline when it comes to both hospice and palliative care in terms of how we provide care for patients with serious chronic illness. So what are the differences from palliative care and hospice? And that's really the identity crisis I was alluding to earlier, that a lot of times people kind of equate us as being the same. And the slide's a little bit busy and not as focused as I'd like it to be, but I can tell you as you read down the line here, just these should be parallel with each other. And when I was doing this yesterday, apparently I fell asleep. So who can receive care? Under palliative care, it's anyone with a serious illness, regardless of life expectancy. There doesn't have to be a definition associated with somebody having months to live, which is pretty classic for hospice care. In order to be enrolled in a hospice program, a physician or two physicians, depending on the state you're in, have to be willing to state that they believe their patient has less than six months or less to live. Is it covered under Medicare? The answer to that is yes, for both disciplines. Is it covered under Medicaid? Certainly some treatments are covered, some medications are covered. Medicare pays for hospice care, though, just for the care related to their hospice diagnosis. So if you are entering a hospice program because of your heart failure, Medicare would pay for hospice care as it relates to your heart failure, whether it's your diuretics or oxygen or medications for chest pain, those kind of things related directly to your heart failure. What they don't pay for would be if you're diabetic, they wouldn't pay for your insulin under your hospice benefit because that would not be considered part of your hospice diagnosis. How long can you receive care under palliative care? It depends on what your care needs are. We have people who come and see us over the course of several years. We have patients who see us more intensely over the course of weeks to months. In the hospice programs, you can continue to receive care as long as you meet hospice criteria. Certainly, there are patients in hospice programs who over time improve to the point where they don't need hospice care anymore, and the 6-month window is no longer applicable, and so they kind of graduate, if you will, from the hospice training or from the hospice program. Obviously, you can re-enter hospice at any time if the condition changes, but there are certainly more than a handful of people who, when they get into hospice, do a little bit better and do not continue in hospice care over the long run. Services for palliative care and for hospice can be provided in any setting, whether it's in somebody's home, in a skilled nursing facility, in an assisted living environment, or even in the hospital. And that's true for hospice's care as well, except for in the hospital. Hospice in the hospital is usually provided by the palliative care services associated with them. There are very few, if any, hospitals that actually have dedicated hospice units. I think the VA has one in town here, but I don't know of any other hospital that actually have dedicated hospice units associated with them. So what's the problem? My friend Calvin and Hobbes is trying to sell a good swift kick in the butt. And he says, business is terrible. It's hard to believe. I can't understand it. Everybody I know needs what I'm selling. So I think the part that I'm getting to now is, when we have these conversations around LVADs and we have conversations around destination therapies, as we age and as we continue down the pathway of our aging, oftentimes it comes along side by side with ongoing chronic illnesses, whether it's, as Val alluded to, ongoing heart failure or just the accumulation of other medical problems that continue to slowly worsen over age. I can speak about LVADs and Val can speak about LVADs, but you are the most vital part of this team. It's your lived experience. It's your life that provides the real insights and expertise to conversations that we have. We can talk from our medical training and from our experiences about how we believe we can help you. But the bottom line is decisions around VAD therapy, how long you want to have VAD therapy, discontinuation of VAD therapy. Those are all conversations that should be had between you, your primary care physicians, your specialists, and especially your family and the people close to you. So how do you know when the LVAD is no longer kind of providing the quality of life improvement that you once had? The months and years hopefully go by, and then this someday arrives. We all have this someday out there when things are going to be as wonderful as they are. Our health will start to slip away. Some of the things we used to be able to do, we can no longer do anymore without assistance. The quality of life of coming to the hospital, perhaps, for frequent issues that are starting to come along, starts to deny us time with our families. We have patients who come into the hospital and they're here for 5 or 6 admissions over the course of 6 months. And that's all wonderful and well and good if we can help them feel better. But there are also times when it feels like we're just losing ground, and the quality of life conversations start to need to bubble to the surface about, am I spending my valuable time where I could be home with my loved ones and watching the sunset with my dog on the dock? Or am I here in the hospital chasing a hopeful situation that may or may not become reality? And it's probably time to have those conversations then, to have, as hard as they are, I call them the hard but loving conversations. It's hard to go into those discussions with people we care about deeply. It's hard to talk to them about our physicians and our colleagues in the hospital and our team members, because everyone's rooting for you and wanting the best for you. And as I mentioned earlier, though, none of us are living with this. None of us have those things in our chests and the lines associated with them and all the self-care that goes along with living with a VAD as part of who you are. So we reach that place. You've got 6 months, but with aggressive treatment, we can make it seem like much longer. We reach those places. We reach that someday. It comes and sits in our lap and demands our attention. So what are some considerations for discontinuation of LVAD? Leading clinical changes leading to discontinuation include stroke. Dr. Val mentioned, that stroke is not an uncommon thing for patients who've had a VAD. In fact, the overall percentage, I think the overall lifetime risk for stroke is 18% in the data that I read. Another one would be sepsis or a systemic bacterial infection, whether it's from a driveline infection that's gotten worse or from just other bacterial infections, perhaps sprouting from a pneumonia or something like that. So people getting recurrently very, very sick, requiring intensive care unit management for sepsis with an LVAD device can oftentimes be a precursor for conversations around whether this is going to be helpful on a longer term basis, or if we're starting to talk about different set of circumstances. Multi-system organ failure, it's pretty common for patients who have LVADs in place supporting their heart function to also have other organs that get involved. The liver becomes affected by perhaps continuing heart failure and decreased blood flows. The kidneys especially are susceptible to heart failure and decreased blood flow. And so kidney failure associated with heart disease is a pretty common finding, sometimes leading to the point of patients needing dialysis. And a lot of people live on dialysis. It requires, another intense aspect of self-care where you're going to a facility 2 or 3 times a week to receive dialysis for hours at a time. And while that seems, like maybe something we can do, I know my experience of caring for patients on dialysis is it's not a pristine quality of life. It usually is associated with a lot of fatigue, not feeling well, having some nausea. It's even though you're sitting in a chair or laying in a bed getting dialysis, it doesn't seem like you're working hard. Physiologically, your body's working very hard to go through the dialysis experience. When patients have LVADs, dialysis units are few and far between that will help take care of you. The LVAD device is obviously not as well known to a lot of dialysis nurses as it is to cardiac nurses. And so their ability to understand the device and to work with the device when it comes to shifting all kinds of bodily fluids is really pretty difficult. As far as I know, there are only like 2 or 3 dialysis units in the entire state that actually will manage patients with LVAD devices in place. And again, if you live in the Twin Cities, it probably isn't a big deal. But if you're living as the 5th generation on a family farm up in East Lake Wobegon, leaving there to move to the cities to receive dialysis is something to think about, perhaps even before you have the device implanted. Is that something that you are willing to forego to continue living with this device, or is that like a line in the sand? Like, I'm not going to do that. And again, the hard but loving conversations are around what expectations do I have for this device and my lifestyle, and what kinds of things are going to be kind of those lines in the sand where they would not be acceptable. The other decision about stopping dialysis would be, as I mentioned earlier, the intolerance or decision to forego hemodialysis. So if you reach the point where hemodialysis is too burdensome, discontinuing hemodialysis would go along hand in hand with the idea of discontinuing LVAD support. Secondary health concerns for discontinuation: as we move through our lives, other health concerns arise. Sometimes patients who have LVADs continue to go on to develop advanced cancers. Sometimes patients develop dementia, accidents, unforeseen things that happen, head traumas that would result in unacceptable quality of life or outcomes in terms of like vegetative states and those kind of things. Again, those all may be reasons to withdraw LVAD support. Patients may request the withdrawal of life-sustaining interventions at any time. These devices are considered kind of extraordinary measures, and the withdrawal of extraordinary measures is well within somebody's autonomy rights when it comes to ethical considerations. So if you've reached a place, or an LVAD patient in our system has reached a place where they don't feel that the quality of life they're experiencing is acceptable anymore, that their hospitalizations and their pain and their recurrent infections and their kidney failure has now led to a quality of life that's no longer sustainable for them, there is a means and a way, ethically and morally, for us to withdraw the device and enter a different phase of life at that point. So, this is the reality of resuscitation. This is the reality of the things that would happen in the setting of cardiac arrest with a device or without a device. This is what CPR and code looks like in a hospital setting. Obviously, it's not peaceful and pristine. It's chaotic and noisy, and not the choice for a lot of people as we move through our lives associated with ongoing burdens of chronic illnesses, whether it's heart disease or kidney failure or cancers or those kind of debilitating illnesses. It's time, if you haven't already, and if you have, it's time to revisit the hard but loving conversations. I tell patients all the time, it's always too early to talk about these things until it's too late to talk about these things. Sitting down with your family and having a heartfelt discussion about the things you would want and the things you wouldn't want goes so far to rendering people able to live through the loss of a loved one, because they can hear their voice say, it's okay to do this, but it's not okay to do that. And I think having those conversations and repeating those conversations as time goes along is certainly essential to helping your family get through the difficulty of perhaps you approaching the end of your life. And I'll take you back in your memory to a slide that Val showed us about the A, B, C, and D, and that patients, kind of having the slow dwindles after a time, as he talked about. D was the green bar that went pretty much straight across and then kind of precipitously fell off. And I've had some patients tell me that that's the Niagara Falls trajectory of their illness. That's what they want. They want to live life to the fullest, and then at the end just fall off the waterfall. That would be a nice way for us to always think about it, I think. So when we make comfort care decisions, what does that mean? What does it mean to be talking about these difficult topics of withdrawing support, even though we've invested our lives over the past few years in working with this device and caring for ourselves with this device and managing our symptoms and helping our families, and our families helping us cope and tolerate with that? What's involved with that decision? When you're talking about discontinuing VAD support, things to talk about is, again, I'll come back to it's your lived experience and your life that provides the insights and expertise. No one is living with this device in their chests except for you. And you are the ones who carry the insights and the heartfelt kind of need to have conversations around this stuff as you reach a place perhaps where the quality of life is starting to change. Your family and your ethical concerns need to be addressed. It's important to sit with your family and talk to them about what their concerns would be. Hopefully you had some of those conversations even with the palliative care team before your implantation was done. Back in 2002, as I mentioned, when heart failure destination therapy use for VADs was approved, the other thing that changed was the Joint Commission on Hospitals said that to be accepted for a VAD implantation, you had to have a palliative care consultation. So we are part of the evaluation process now for any patients who are receiving evaluations for LVAD implantation, especially for destination therapy or for heart transplantation for that matter. If you're considering discontinuation of the VAD support, your DNR status needs to be affirmed. Other life-sustaining interventions need to be discontinued or at least discussed. Defibrillators need to be looked at and disabled. Vasopressor medications that support blood pressure, usually these are in the intensive care unit setting, but those would have to be discontinued. Oftentimes dialysis would also be discontinued at the time a decision was made to stop LVADs. Tube feedings and those support interventions would also be considered to be stopped. And obviously ventilators or machines to help us maintain respirations and breathing would be discontinued at that time as well. LVAD deactivation needs to be done by an RN trained in LVAD systems. Most of you probably have a very close relationship with your RN VAD coordinator, and they are also specifically trained in alarm management. We don't want a discontinuation of an LVAD to be full of alarms and bells and whistles. It should be a peaceful time. Without those, you can add the explicitive for yourselves, without those alarms going off. In addition, it should be done in the presence of a physician or a trained provider in end-of-life cares to make sure that you're comfortable, that you're not experiencing shortness of breath or pain, that you're not having anxiety. All those things can be done in the context of either a facility or in the context of your home. And I think that's the last point I'll make about that is it may be done at home, surrounded by family if you choose. You don't have to be in the hospital to have this VAD device discontinued. Medications for managing pain or shortness of breath or anxiety should be given prior to deactivation to make sure that circulation happens, because once the VAD is discontinued, there's no real rhyme or reason to know which patients are going to leave us really quickly or which ones might linger for several hours, perhaps even days, depending on their underlying heart function and their ability to maintain their blood pressure and the like. So we reach that place of loving care across your lifespan. Your family gathers around you and supports you and says the things that need to be said, and you are able to share that meaningful opportunity with them as well. So here we are at the edge of all things. Once discontinued, circulation may diminish rapidly, and I've seen it happen over the course of minutes. I also seen it happen over the course of hours to days. I'll close with a couple of thoughts. One is we know how this ends. There was a wonderful book by a gentleman you're seeing a picture of named Bruce Kramer, who was the Dean of Communication at St. Thomas College. And Bruce developed ALS and wrote a wonderful book called We Know How This Ends with a woman named Kathy Werzer, who's a NPR radio personality here in town. And one of the lines from his book that I quote all the time is, "Disease fools us into thinking that a cure is the only healing story." Let me say that one more time. Disease, no matter what it is, whether it's ALS or end-stage heart failure, fools us into thinking that a cure is the only healing story. I've had so many patients tell me that they've been more healed and had more joy because of the influence of their life-limiting diagnosis in their relationships, and how people are more honest and upfront and sharing of their emotional depth of care for each other in the course of illness, and that those are healing experiences for people, whether it's curative or not. They're healing experiences. So I'm going to go back to screens. Time for kind of questions or comments. I encourage your thoughts. Come on in, the water's fine. This is the Temperance River up north. And again, just thanking you in advance for your time and interest and attention to this vital part of the care we're providing for you.
Michael, thank you. And, Val, thank you as well. A lot of information there, covered a lot of tough things. If you have questions, go ahead and put those in the chat. I've got a couple that I'll just kind of lean right into out the gate. One is, I'll start with this. Those that know me personally know I'm about like squeezing everything out of it almost, as you said, Michael. And so, Val, is there study data available yet? Or what is believed general, like just your own personal view, consensus with HeartMate 3? And, we realize with each generation of the VAD devices, longevity has occurred, and and we know some folks out there that are even 10 years out and more than that. Your perspective on that, what do you think that might look like?
Yeah, I think eventually, especially as like I know I see Dustin's on the call and Tim Chase was here earlier, but especially as the technology gets better and better, they're looking at other ways to really make it easier for patients to use, smaller devices, easier to implant. I would not be surprised if, within the next generation, we start to get average survival approaching 10 years, for example, or even surpassing transplant at some point. That would not surprise me for that to happen within my career. So I think how much progression that has really happened in the last 20 years. And to be frank and to be honest, I've really only had experience with the HeartMate 3 and occasionally the 2, so I'm not as familiar with some of the older devices, but I think it's a fantastic device, and I think there'll be just continuous improvements as we go forward.
Great. One quick note, Michael, you're still on a screen share. If you want to kill off your screen share there, there you go, right there, that one. Hey, great. Okay. Wonderful. Now, another question along those lines, and that is, and I was actually at a point. I'm going to give a comparison, and maybe you can comment on how this can relate specific in the permanent MCS world, the VAD world. But realizing, it's only been in the last, it's been under 3 years. In 2018, they changed the protocols for transplant prioritization, right, and the stages of those, and because of that, we saw a real shift in who's getting hearts, and certainly Dr. Cogswell talked about that, and that happened in a very short amount of time because of the technology itself in the temporary MCS world.
Yeah,
pretty significant on a positive note, meaning that temporary MCS works extremely well. Well, now we're in the permanent MCS discussion here. And is it, what's the likelihood of that? We're talking about, so people who are on here on the call today, I'm not asking for you to commit, oh yeah, within 3 years, we're going to do this. I mean,
sure.
We can talk to Dustin about that during our futures session coming up next Wednesday. But what do you think what do you have a point of view around how quickly some of these can change?
Sure. And we all know that the allocation changed, fall of 2018. And again, to be frank, it's the allocation system that I kind of, you could say, grew up with, so to speak. I wasn't as familiar with the prior one. I think a lot of people believed that the old allocation system needed to be changed. And then there are a lot of pros and cons to this newer one, and especially as you alluded to earlier, that, it tends to favor those sicker patients
Yeah.
requiring those temporary devices. And
And let me
uh,
help you with this, because
yeah,
Dr. Cogswell spent, an hour with us on this just 2 weeks
oh,
ago.
sure.
So the setup is really the impact of what happened with that was due to temporary MCS.
Hmm.
As you're well, and folks that are on the call here, if they sat in before, they know that that was the change factor that really kind of, was the unexpected consequence because of the rapid change in temporary MCS. So, do you think, are those kinds of things possible in a shorter horizon as well in a permanent MCS world? Because of the advent of HeartMate 3, as an example.
Yeah, I mean, I think it depends on how, if we stay with this allocation system, and if there are thoughts about changing it to a different system, and talking about like a heart score similar to a lung score. Um, I think no one really knows what the future will be like for permanent or durable MCS in relation to how that affects transplant and other temporary MCS devices. So I think we just have to kind of play it out and see what happens.
Okay, sure. Fair enough. Uh, Michael, question for you. Uh, you spent a little bit of time around dialysis there. And, I know I can speak firsthand as well that going to a dialysis clinic and that just rigor and the challenges and the feelings that come from them physically is extremely difficult. Um, but I also know that there's a better way for some, which is either, say, peritoneal dialysis at home done by oneself, or even home hemo. Are you aware of any, VAD patients that are doing one of the options, because they seem to be a little easier on the body as well, right? You don't get all the ups and downs and sways with the electrolytes.
I am not aware. Perhaps Val, you have in your experience know of patients. I know there's a subset of patients that qualify for peritoneal and home hemo, and I think it sometimes has not only to do with their own physiologic function, but also the support network they have at home, the people who are available to support them and that kind of thing. And obviously that varies from individual to individual. I would agree if those options are available to a patient and can keep you from having to leave your fifth generation estate, it certainly would be something to consider rather than having to relocate to a center where you could do dialysis. Yeah. Val, do you have any patients who are doing peritoneal dialysis?
Yeah, I don't think, and I think peritoneal dialysis would be tough, especially with the drive line in place and just the risk of infection.
Yeah.
From that standpoint. So I think from that perspective, we don't necessarily do peritoneal. At least I haven't heard of anyone going through peritoneal. And then yeah, no, it's a tough situation when you have an LVAD and you need dialysis, that I think they would want more monitoring at a unit compared to home dialysis. So
Got it. Good, good. I don't know if either of you had received any questions directly. If I didn't see any here.
no, I don't see any.
Okay, I've got another then. And Michael, it's really for you. It was a great diagram that Val had depicting, in essence, what is, we'll pick it up at pre-heart failure into what would be heart failure into advanced heart failure. And there are stages to that. And, medically, I know they have definitions for those things. And all of this on this call have experienced those. I guess my question lies with Michael, when should palliative be considered across that spectrum? I mean, I could say, well, once you have an inotrope, well, you're in a stage of heart failure, right? Once you're on a temporary device, well, you're absolutely in advanced heart failure. And there's some better clinical definitions of that. But do you have some suggestions for people on the call? Because you did a wonderful job, kind of that end of life section. But I think about living and maximizing the quality of that time, knowing that horizon, as we saw in Val's diagram, can actually be quite a while for some.
Yeah. Yeah, thanks for the question. My own bias is that palliative care, like other subspecialty disciplines in their relationships with patients, works when we have relationships. And I think my own bias would be at the time of diagnosis of heart failure, palliative care should be consulted. Not because somebody needs to talk about end of life things perhaps at that point, but perhaps just to introduce the concepts of palliative care, to talk about symptom management, to talk about quality of life concerns as they may come along, to start to facilitate those, again, hard but loving conversations around, are there things that you would find unacceptable over the course of your illness that would lead you to a path of choosing perhaps not to have further interventions or have a limited treatment plan? When I talk to patients who are enrolling in hospice, it's really about enrolling early, because it's the relationships with the people providing the care that make it a meaningful experience for both parties, right? So if you're waiting until heart failure is so advanced that you're requiring home inotropes, it may mean that I don't have time to establish a trusting relationship with you so that you and your family can relate to me and me to you about your circumstances and get to know each other, so that we're making really good decisions based on our mutual experiences of your illness with each other, rather than having it be kind of a last minute, let's add palliative care now to the equation. I think Val probably agrees that usually earlier on in the course of illness, especially when you're talking about a progressive chronic illness like heart failure, I mean, the things we're talking about doing are all temporizing measures, right? They don't fix the heart failure. We all temporize all the symptoms as best we can throughout the course of illness. So a lot of the stuff is palliative. A lot of the stuff is symptom management approaches to the care that patients need through the course of this ongoing chronic illness. So I would say, as early as we can, to introduce the concepts of palliative care to patients in heart failure. I don't know, Val, if you want to add to that or not. But
No, I completely agree. I think earlier the better. I think there's been a lot of data within other diseases as well, especially cancer diseases, that early upfront palliative care is quite beneficial for patients in terms of their quality of life as well as quantity.
Yeah. And for what it's worth, I'll just share for those. I believe it was the second conversation I had with Dr. Cogswell ever, when she said, I think you should think about palliative care. And I didn't even, my first thing I thought was, what was it? My second thought was, hospice, really? That was 6 years ago. So, yeah, it's, if you're not familiar, I couldn't recommend them enough.
I think they do a great job with us.
Yeah. Okay. That said, any other closing remarks from either of you? Otherwise, I think we'll call this one a wrap. But
happy to be here, happy to take part in this, and it's a good discussion.
yeah. Thank you for the invitation and ability to be part of it. Yeah, very good conversation. Thank you.
Yeah. So thank you everyone for joining. As a reminder, we've got another session next week. Remember, it's next week, not in 2 weeks, on Wednesday at noon, where we'll be talking about tips, tricks, and futures around VAD. And should be a fun session. Come with suggestions for your fellow recipients. So that said, we'll bid adieu, and to leave, you just simply hit the leave button up on top, and the meeting will resolve itself. So thank you again. Have a great day.
Take care.